back to the IPC Masterclass Session 4. So today we have with us uh, Dr. Fatima Khan, who is an Associate Professor at the Aligarh Muslim University. Welcome, Doctor, to this platform. And before we begin the session, I would like to once again introduce you all with our moderator for the session, Dr. Sukanya. So I think many of you know Dr. Sukanya for she has already moderated one session with us, and she has been a part and parcel of IPC Masterclass since its very inception from IPC Masterclass Season 1. So, short introduction for those who have joined for this session new. Dr. Sukanya is a clinical microbiologist and certified in infection prevention and control, and she is an internal auditor for NABL, NABH, and she is also published her articles in peer-reviewed journals. And she's currently a consultant with MedGenome Laboratories in Bangalore and also a visiting faculty with Care Institute Health Sciences and diploma in Infection Prevention Control, run by Infection Control Academy of India and University of Hyderabad. And also, she is the national faculty for IPC and WASH training and mentorship program by UNICEF India and CDC in collaboration with ASCII. So she has many accolades and she has a vast experience. So she is going to take us forward through the session. So over to you, Dr. Sukanya, for the
Thank you.
session.
Yeah, good afternoon. And thank you, Lalit, again for the generous introduction as always. So good afternoon to all of you. And, it's really wonderful to always collaborate with SANMED and IFCAI in this journey of academic research, learning, and enrichment of knowledge. It's always a very interactive platform. And I hope that the series of webinar really actually helps all of you to come out with challenges from your side, and we can make it interactive. I think you should the participants should interact with the speaker, and that's my job to moderate that. So once again, thank you all for joining, and I would now like to introduce our speaker for this session, Dr. Fatima Khan. Good afternoon, ma'am, and warm welcome to you. Ma'am is a microbiologist with over 12 years of experience in academics and research. And currently, she's working as an associate professor in the Aligarh Muslim University. And she's certified in hospital infection control and good antibiotic prescription practices. Dr. Fatima is she also serves on the editorial board of the IJCMAS, that is the Indian Journal for clinical clinical microbiology and applied sciences. I'm not sure. Yeah, okay. And also the Journal of Vaccine and Immune Technology. She is also the founder secretary for the HISI Aligarh chapter, and is a reputed speaker also at various national conferences. Dr. Fatima has also authored many articles in journals of international repute, and her commitment and passion is very evident in her initiatives during the COVID-19 pandemic, wherein she has organized training for over 600 doctors and over 250 nursing staff at her university. And she has also been instrumental in developing policies in IPC during the COVID-19 pandemic. So a great, a wonderful, and a very nice, experienced speaker for all of you today. I warmly welcome you, ma'am. And I hope that the session is very interactive and we have a pleasant interaction throughout. Thank you. So over to you, Dr. Fatima.
Thank you, Dr. Sukanya, for the generous introduction. And thank you, Mr. Lalit, for providing me this opportunity to interact with such enthusiastic audiences. And I think before wasting much time, we should move on towards today's session. Let me just share my... Okay.
Doctor, there is a present now button towards the bottom of your screen.
Yeah. Hmm.
So once you select that, select your entire screen.
Yeah, I did that.
Yeah, and from your entire screen, you must have the PPT open in your system.
Hmm.
Okay, so
Yeah.
once you press on share your entire screen, you can go and open the
It is
PPT.
not allowing me to press the share button.
Just a minute. Spurti?
Ma'am, you need to click on that, ma'am. Click on that particular window, and then it will be enabled. Share button will be enabled.
Yeah.
My presentation is visible?
Yes, it's visible. You can
Oh,
make it full screen now.
okay. Fine.
Yeah, perfect.
So a very warm good evening, good afternoon to all of you. We are here to discuss about the outbreak management for healthcare associated infections, also known as the hospital acquired infections. So let us just begin with the definition of what healthcare associated infections are. Any infection developing in a patient after 2 days of hospital admission and was not present or incubating at the time of hospital admission will be considered as a healthcare associated infections. They're also termed as nosocomial infections. And the four major healthcare associated infections that we do surveillance for and that we are concerned with are catheter associated urinary tract infections, catheter related bloodstream infections, ventilator associated pneumonias, and surgical site infections. Apart from these, there can be a number of other types of healthcare associated infections also, like MRSA outbreak or sort of things. So, why are we so much concerned about the healthcare associated infections? This is one of my favorite fact sheet of WHO about the healthcare associated infection. And I show this in almost all my presentations, highlighting the important points which I want to highlight in that presentation. So, just once again, the important highlights of this fact sheet: of every 100 hospitalized, oh, there's some echo. Is it okay? Of every 100 hospitalized patients at any given time, 7 in developed and 10 in the developing countries will acquire at least one healthcare associated infection. UTIs are the most frequent HCAI in high income countries, whereas surgical site infection is the leading infection in settings with limited resources like ours. I'm talking about the Indian subcontinent, affecting up to one third of operated patients. This is up to 9 times higher than in the developed countries. In low and middle income countries, again like ours, the frequency of ICU acquired infections is at least 2 to 3 times higher than in the developed countries, and the rate of ICU acquired infections in developed countries is approximately 30% of the admitted patients. So if we make it 2 to 3 times higher, that it makes 60 to 90% of all patients that are admitted. That is, out of 10 patients, 6 to 9 patients are at risk of developing healthcare associated infection in an ICU. The device associated infection densities are up to 13 times higher than in the developed countries. So, whenever there is an intervention done in a hospital, it increases the chances of developing HCAIs, and thus the patients are more prone to developing infections. So, why do these healthcare associated infections occur? Because there is the healthcare, there are a hub of microorganisms, there are immunocompromised patients, and there is transmission of pathogens between the staff, from the staff to the patients, and vice versa, and amongst the patients, all these leading up to the nosocomial infections. So sometimes these nosocomial infections may occur in the form of an outbreak. So let us just go through the definition of the outbreak. What is an outbreak? An outbreak refers to occurrence of a disease at a rate greater than expected within a specific geographical area or over a defined period of time. Two or more linked cases of the same illness, or the situation where the observed number of cases exceeds the expected number, or a single case, even a single case of a rare disease caused by a significant pathogen, for example, the viral hemorrhagic fevers like we had Ebola or Nipah outbreak in Kerala. So we must understand that outbreak is an emergency situation. There have been multiple outbreaks in the community like cholera, food poisoning, influenza, malaria, chikungunya, hepatitis A, and anthrax, and so on and so forth. And these are the pictures of few of the important outbreaks which shook the world up to 2016. This was up to 2016. I was just scrolling the important outbreaks that occurred, and we had Ebola, polio, smallpox, cholera, Zika virus, uh, malaria. When we move on to 2020, we all have outbreak or pandemic, what is now it is called, followed by a recent monkeypox outbreak. So outbreaks are there to occur. What we are supposed to do is to know how to curtail an outbreak. And more important thing is to differentiate an outbreak from a cluster. So what is a cluster? It is an aggregation of cases in a given area over a particular period without regard to the previous number of cases. And it must be differentiated from an outbreak. My next question is, does outbreaks occur in healthcare settings? We have seen a number of outbreaks. We have grown through the COVID-19 pandemic. All these were community acquired. Do we have outbreaks in healthcare settings? Which of, yes, we do have outbreaks in the healthcare settings. Now I have a question for all of you. Which of the following situations shall be considered as an outbreak in a hospital? You can answer in the chat box. 2 adult patients with COPD develop pneumonia after admission to the medicine ward. 1 patient admitted in surgery ward develops purulent discharge at the surgical site. 10 postpartum women develop wound adhesions between 1 week to 2 weeks of the cesarean section, and 2 cases of varicella in pediatric ICU within 5 days. So of all these 4 situations, what all will you consider as an outbreak? There can be more than one answer also. Please answer in the chat box. I hope, Lalit, you can see the answers. I am unable to see that.
Yeah. So most of them are like C and D.
Okay, very good. So that was the answer I was expecting, that because there is a cluster of cases, more than the expected number of cases of postpartum women developing wound dehiscence, this will be considered as an outbreak, or even 2 cases in a pediatric ICU within 5 days. This is a severe disease that will be considered as an outbreak again. So once an outbreak occurs, how are we going to move forward? There should be a general outbreak control guideline in a hospital which must be reviewed periodically and updated every 1 to 2 years or whenever required. The objectives of outbreak investigations are to define the magnitude of the epidemic or outbreak involvement in terms of time, place, and person, to determine the particular conditions and factors responsible for the occurrence of the outbreak, to identify the causative agent, sources of infection, and modes of transmission, and to make recommendations to prevent its recurrence. But most important of all, the primary objective of the outbreak investigation is to stop the spread. So once we are into the outbreak investigation, there is a 10-step approach, that is we have to follow these steps one by one. Number first is to identify the investigation team and resources, establish existence of an outbreak, verify the diagnosis, construct case definition, find cases systematically and develop line listing, perform descriptive epidemiology, develop the hypothesis, evaluate the hypothesis, then perform additional studies as necessary, implement control measures, communicate findings, and maintain surveillance. So we'll be discussing all these points one by one. So first thing is to identify the investigation team and resources. Once an outbreak is suspected, notify the appropriate individuals and departments in the institution. Establish an outbreak investigation team with clear delineation of the responsibilities. Cooperation of various healthcare professionals is essential for efficient investigation and implementation of control measures. Identify the available resources, the personnel, the supplies, and the laboratories. So the first thing is to form an outbreak investigation team. So who should be the part of an outbreak investigation team? It is basically
Ma'am, screen is not visible.
Doctor, I think you have stopped sharing.
No? Shall I stop sharing and start sharing it again?
Yes.
Is it okay?
Yeah. Make it full screen. Yeah.
So, an outbreak investigation team is a multidisciplinary group which work together to investigate an outbreak, and an infection control staff must be a part of the outbreak team. Other members include local hospital epidemiologists, microbiologists, other trained medical or clinical personnel, public relations officers, and one of these members of this outbreak investigation team should be designated as the team leader, who coordinates all the response activity of the team and acts as a primary point of contact. So the role of outbreak investigation team is to facilitate the investigation of the outbreak, and it performs the following actions. It draws a detailed outbreak control plan, clearly addressing the areas of individual responsibilities and action plans of all the members involved, uh, uh, making the duties clear cut to all the individuals, implements and monitors various control measures, which may include full implementation of infection control measures as recommended by the HICC, special cleaning and disinfection procedures, oversees communication to all the relevant groups, and facilitates the medical care of patients with the involvement of the relevant clinical team. So now the individual responsibilities of different teams which form the component of the outbreak investigation team. The role of the treating clinical team is to inform all the suspected outbreaks to all the members of the outbreak control team, isolate the suspected cases as soon as possible to contain the spread of infections, record information on all cases with date of admission, time of onset of symptoms, clinical diagnosis, etc. Relevant specimens should be sent for investigation to the laboratory after consultation with the members of the HICC committee and the clinical microbiologist. Restrict the movement of the staff, patients, and visitors, and more importantly, train other physicians on treatment and prophylaxis guideline. And we have seen the importance of this training during the COVID pandemic, when not only the medicine specialists, but other staff members were also incorporated in treating the patients. And the role of the HICC is to ensure the implementation of infection control measures, including the standard and transmission-based precautions, to organize educational sessions and training on reinforcing the infection control practices to the healthcare workers, assist the epidemiologist for the line listing the cases and establishing the cases, arrange for appropriate pre and post exposure prophylaxis, including the staff vaccination, and assisting the clinical team in active surveillance for case finding. The role of microbiology laboratory during the outbreak is to perform the culture and antimicrobial sensitivity if it is a bacterial outbreak, accurately identify the causative organisms to the species level, identifying the suspected outbreak through establishing an epidemiological link between the outbreak isolates and the environmental samples, etc., and matching their antimicrogram or other type by using other typing methods, perform environmental surveillance, collecting these samples from the suspected source, and surface air and water sampling to trace the source, carry out staff screening if, for example, we are suspecting an MRSA outbreak or an MDRO outbreak to determine the source of infection. The role of an epidemiologist is to formulate a case definition, classify cases into suspect, probable, confirmed, or ruled out, maintain a current line listing of cases, and construct the epidemic curve, which helps us in identifying the type of the outbreak, conducts active and enhanced surveillance prospectively and or retrospectively for detecting the missed cases, maintain the documentation of all information and report and notify to the concerned authorities, ensures that final report of the outbreak is submitted within 30 days of the end of the outbreak. The role of the administrator, any of the team members will not be able to perform the roles properly if there is not administrative support. So the administrator is the most important member of the outbreak investigation team, or for that matter, for any activity, for any healthcare worker activity. So these administrators, they must ensure that there are sufficient resources within or from the outside source to respond to the outbreak and control its spread. And they also help in motivating, providing incentives and to those who are working hard. So that helps in curtailing any sort of infection. They must ensure the provision of PPEs, drugs, disinfectants, vaccine, stationaries, reimbursement to the healthcare workers or infection control team for additional working hours. That works as an incentive. So that was the first step, that is formation of the outbreak investigation team. Now this team will help us in the confirmation of the outbreak. So confirm whether there is an outbreak by reviewing the preliminary information on the number of potential cases from the microbiology, from the available microbiology, from the severity of the problem, demographic data of the cases, place and time. Then the immediate control measures have to be taken place to reinforce these on standard precautions and other transmission-based precautions depending on the type of the pathogen that is suspected. So accordingly, the airborne, droplet or contact precautions are to be followed. And unless and until we are sure that what is the pathogen involved, then we are supposed to follow all the precautions. Then notify and communicate so that the healthcare workers in the immediate area, HICC and administrators for control measures, the laboratory for further testing for epidemiological typing, and the integrated disease surveillance program if it is a notifiable disease, like in case not in India, but for example, yellow fever. So it is a notifiable disease. So this is to be followed by to ascertain the reliability of both clinical and laboratory information. Then compare with the baseline data for HAI surveillance data, and then determine if the observed number of cases are more than the expected cases. More important is to rule out the pseudo outbreaks, such as we'll discuss the pseudo outbreaks in later slides, and differentiating between the outbreak and cluster of cases. If outbreak is not confirmed, then the clinical team who have reported the outbreak should be informed. So we were talking about pseudo outbreaks. Pseudo outbreaks are defined as real clustering of pseudo outbreaks are defined as real clustering of false infections or artifactual clustering of real infections. They occur when an increased number of positive tests are evidenced in the laboratory without the presence of the true outbreak. And there are several reasons which can give rise to pseudo outbreaks. For example, the laboratory factors, like we have a new test, which is more sensitive. A newly trained technician has joined the laboratory, or there is contaminant or normal flora or colonizers which are interpreted as pathogen. Approximately 50% of the pseudo outbreaks, they are due to the errors in the microbiology lab processing. Then there are surveillance factors due to the introduction of new method of surveillance or change in the HAI definition that can also increase the case count, or the environmental factors like due to the contaminated tap water in the endoscope, cleaning and performing the ZN stain. So that can lead to increased number of cases, or administrative factors. So like we have increased number of cases because of the local or national awareness or due to any new policy. That will all lead to falsely positive reporting of cases, high number of cases. So once we have confirmed that the outbreak is there, then we have to verify the diagnosis. It comprises of the following steps. It is important to ensure that the disease has been properly identified, as the control measures are often disease specific. So we have to review the clinical findings, the laboratory results, and request additional laboratory tests if necessary. Multidisciplinary team should visit the patient to re-elicit the clinical details and the history of the cases. Then this team will summarize the clinical features using the frequency distribution, which is useful in characterizing the spectrum of illness, verifying the diagnosis, and developing case definition. And again, they'll review the scientific literature to confirm this diagnosis. This closely resembles to step one, that is establishing the existence of the outbreak. So we are again actually reviewing what we hypothesized in the first in um, defining the outbreak. So once we have verified the diagnosis, then the epidemiologists, they are supposed to construct the case definition. Case definition is a set of standard criteria for classifying whether a person has a particular disease, syndrome, or other health condition. It should be made in such a way that it includes most, if not all, the cases, but very few or no false positive cases are included. It decides what constitutes a case, what you are looking for, define three essential characteristics of the disease, that is the person who may be involved, the place, and the time. A gradient of definition based on the level of evidence, like suspected, probable, or definite and confirmed case, is often helpful and usually made. We have seen these definitions in COVID time also. Now, the cases, they are classified as confirmed, which are usually laboratory verified, probable based on the clinical features, and suspect usually have fewer typical clinical features. Probable cases have typical clinical features, and also they have contact with the suspect cases or confirmed cases. So at the start of an outbreak, a broad case definition can be used, which can be narrowed down at a later date by dropping out the suspect and probable cases when more information is available from the clinical and laboratory investigations. So this is an example of Japanese encephalitis, definitions of suspect case, probable case, and confirmed case. We can see the suspect case is based on clinical features. The probable case is based on the contact of the suspect with the suspect cases and with confirmed cases. And the confirmed definition is based on the laboratory confirmation along with the clinical features and contact. So sometimes we can use previously published case definition also, which have validated definitions if available, and they are applicable like CDC, NHS, and surveillance definitions for various types of infections. And we use particularly these definitions for healthcare associated outbreaks. Like let us just discuss the few important healthcare associated infection definitions. We discussed that the 4 important healthcare outbreaks that can occur. So according to CDC, a primary bloodstream infection will be defined as laboratory confirmed bloodstream infection that are not secondary to an infection at another body site. Central line associated bloodstream infection, CLABSI, a laboratory confirmed bloodstream infection where central line or umbilical catheter was in place for more than 2 calendar days on the date of event, with the day of evidence device placement being day 1, and the line was also in place on the date of event or the date before. Pneumonia, identified by using a combination of imaging, clinical features, or blood and respiratory specimens, or dyspnea and laboratory criteria. Ventilator associated pneumonia, pneumonia where the patient is on mechanical ventilation for more than 2 calendar days on the date of event, with the day of ventilator placement being day 1, and the ventilator was in place on the date of event or the day before. Then COTI and non-COTI. Non-COTI's patient has at least one of the following features: fever, suprapubic tenderness, costovertebral angle pain or tenderness, urinary frequency, urinary urgency, dysuria, and has a urine culture with no more than 2 species of organisms identified, one of which is a bacterium of more than 10 to the power 5 CFU per ml. COTI is UTI where an indwelling urinary catheter was in place for more than 2 days or the day before, and the patient has clinical signs and symptoms of UTI and has a urine culture with no more than 2 species of organisms identified, and one of the bacterium is more than 10 to the power 5 CFU per ml. These are the sample case definitions. We discussed the few of them. Then how do we classify them based on the person, place, and time? We have to, for example, new progressing abnormalities in a particular ward it is occurring, on a particular HDO or ICU, and the time duration between which it is taking place. So once we have defined the case, formulated the case definition, then we will start hunting for the cases systematically and develop line listing. So how do we find cases? Utilizing the microbiological data, infection control or surveillance records, discussion with the clinicians, pharmacy records, medical records, nursing charts, and pathology reports. So this can be done by active surveillance, by passive surveillance, or by contact tracing. After finding the cases, we need to form the standard case report form, in which we are supposed to have the identifying information, the demographic information, the clinical information, risk factor information, and the reporter information. A standard case report form, such as the questionnaire or a data abstraction form, should be framed to collect the following information about the cases. That is, we discussed the identifying information, demographic information, clinical information, risk factor information, and the reported information. And this is the example of a standard case report form during an outbreak investigation. So once we have a standard case report form, then line listing is to be done. It refers to compiling the critical information from the case report in an organized manner. Typically, it comprises of a spreadsheet with rows and columns, where rows represent the records and columns denote the variables, each representing one characteristic of the cases, such as the demographic information, clinical details, and exposures possibly related to the illness. So this is again an example of the line listing of an investigation of acute gastroenteritis. So now, once we are hunting with the cases, please remember, don't be bogged down with case definitions and capturing all cases. Goal of the outbreak investigation is not to find and describe every case. Our goal, as discussed earlier, the primary objective was to stop the outbreak, so we do not need to find every case. So once we have defined the cases, we have done line listing, now perform the descriptive epidemiology and develop a hypothesis. Examine the distribution of a disease in a specific or defined population at risk. It refers to a process in which the outbreak is classified by the basic features of its distribution in terms of person, place, time, and this helps in providing clues about the etiology, source, and the modes of transmission that can be turned into the testable hypothesis. It assesses the time train, like it is point source or propagated or circulating, recurrent or cyclical, seasonal or combined. So for that, we need to conduct surveillance. Now, surveillance is defined as the ongoing systemic collection, analysis, interpretation, and dissemination of data regarding a health-related event for use in public health action to reduce morbidity and mortality and to improve health. So basic components of a surveillance system includes data collection, procedures for evaluating data and making comparisons, and a means for disseminating the results. Surveillance can be retrospective or active. Retrospective surveillance consists of comprehensive review of sequential events in the medical records and examination of information even after the patient is discharged. That is, we are moving into the past. We are going to seeing the past records to analyze the data. It avoids time-consuming efforts of locating and reviewing the charts. The disadvantage of this is it does not permit interactions with ongoing caregivers or verifying the data collected, because we are seeing the past records. So to overcome this advantage, we have active surveillance or the cross-sectional. This can be in the form of a cross-sectional study or prevalence study. And it identify all the patients with healthcare associated infection hospitalized at a given point in time in the entire hospital or on selected units. It is useful for conducting initial assessment of the current issues before proceeding to a more focused continuing active surveillance program. The outcome measure is a prevalence rate. Then the prospective longitudinal active surveillance is the incidence study. It detects new cases during the surveillance method. It is preferable if the data can be collected regularly and the patient is still under the care of the institution. It is able to capture information in real time, interview the patient's caregivers, interactively obtain or observe findings that may not be recorded in the patient record, more effective in detecting differences in infection rates, to follow the trend, to link the infections to risk factors, and for inter-hospital and inter-unit comparisons. Outcome measures are incidence rates, attack rates, and infection ratio. So this is a prevalence study, cross-sectional. Period prevalences, it includes HAI active on the day of the survey and those active during the predefined period before the survey day. And point prevalences to assess only the HAIs active on the day of the survey. Something has come up on my screen. Okay. Now there is an exercise for the participants. Compute the HAI prevalence rate, the period prevalence, and the point prevalence. The period prevalence of the 7 days. From patient A to patient H, admitted in ward A. The participants can answer in the chat box. Period prevalence is total number of cases during that particular duration of time. And point prevalence is the cases that occur on that single day of observation. So period prevalence in this case comes out to be, because over a 7-day period, we can see there are 5 cases out of the 8 patients admitted. So period prevalence is 5 by 8. And the point prevalence is there are only 2 new cases. So 2 by 8, 25%. Similarly, in the incidence study, incidence is the number of new cases that are occurring over a period of that we are observing. So there are 2 new cases over a period we are observing over a 4 weeks period. There are 2 new cases in the 8 patients that are admitted. So the incidence is again 2 by 8, that is 25%. Then the epidemic curve. It is a simple, easily understood graphical display to depict the time course of an outbreak, and the number of incident cases in an outbreak is displayed on the vertical axis, and the time or date of onset on the horizontal axis. It helps us, the shape of the epidemic curve can provide the following information by the simple visual display of the magnitude and time trend can be seen. It helps us in identifying the source, whether the source of the infection and the pattern of spread of population is point source or continuous or intermittent or propagated, the mode of transmission, the time of exposure, and the type of exposure can be suggested, the incubation period, the current status of the epidemic, whether it is still on the upswing or on the down, or the epidemic is already ended. This information should be the basis for predicting whether more or fewer cases will occur in the near future, and the outliers. Now, the question arises, what are the outliers? The outliers are the cases that do not fit into the body of the curve and lie on either side of the curve. They may have an easily identifiable exposure that may point directly to the source. They may provide important clues such as an early case. An index case may represent an unrelated case, a source of the epidemic, or a person who was exposed earlier than the other cases. For example, a cook who tasted a dish hours before bringing it to the picnic. All late cases may represent unrelated cases with long incubation periods, secondary cases, or persons exposed later than most of the others. For example, someone eating leftover food 2 to 3 days later. So the type of outbreaks based on these epidemiological curves, we can classify the outbreaks into 4 major classes. The common source outbreaks, they can be of 3 types: point source, continuous source, and intermittent source, and the propagated outbreak. All these come in total make 4 types. So the most common epidemic curve that we are going to see is the bell-shaped epidemic curve. The points it occurs in the happens when there is a point source of the outbreak, when a group of people they're exposed to the same source over a brief time, so that everyone who becomes ill does so within one incubation period. Such outbreaks they last for a short duration as the exposure is at one time and is brief. The classic example includes a group of people suffering from food poisoning. The epidemic curve approximates a normal distribution curve if there are sufficient number of cases and if the cases are limited to a short exposure with a maximum incubation of a few days or less. So this is a steep upslope and a more gradual downslope. Then, in a continuous common source outbreak, persons are exposed to the same source, but exposure is prolonged over a period of days, weeks, or months. Example, contamination.
Yeah, I think ma'am has lost electric. I mean, there's some power failure, I suppose. Just wait for ma'am to continue, please. Dr. Fatima, can you hear me?
Yeah, I can hear you. I think I'm back. Uh,
Yeah, yeah.
my slides are visible still? Okay.
Yes, yeah.
Okay, let me just put on the light. There's some issue.
I think just make it full screen. That I think that.
There is some internet issue here, and so that I have switched off my
That's fine,
video.
Dr. Fatima. Please continue.
So we were on the continuous common source outbreak where the persons are exposed to the same source, but exposure is prolonged over a period of days, weeks, or longer. For example, the contaminated water supply or the typhoid Mary, the most common example. A cook who was the carrier and was a source of salmonella infection. The outbreak begins relatively abruptly, suggesting that many people were exposed simultaneously rather than it's spreading from one person to another. This tends to uh, flatten with the peaks widen. It reaches a plateau that is sustained over time until the source is removed. The intermittent common source outbreak is a type of common source outbreak which is not well controlled and exposure occurs intermittently so that the outbreak tends to recur. A propagated outbreak, there is no common source as the outbreak is spread from person to person. This can last longer than the common source outbreak. It begins from the index case, but then develops into a full blown epidemic with secondary cases infecting new people, who in turn serves as source for further cases. So epidemic curve with progressively taller peaks. Peaks are initially separated by one incubation period, but the peaks tend to merge into waves with increasing numbers of cases in each generation. The epidemic continues until the remaining number of susceptible individuals declines or until the intervention measures take effect. So these are the various types of epidemic curves that we discussed. Then there is a thing that is a spot map. A spot map is a simple and useful technique for illustrating where the cases live, work, or may have been exposed, and they help in locating and identifying the cases, identifying the source. So whenever there is an outbreak, particularly from the clinician, we have a pressure of environmental sampling. Although it is a vital part of the investigation, but it should be done with the epidemiological investigation. It should not be the first step in any outbreak investigation. Ideally, epidemiological results guide sample collection. They should not be taken randomly. They can support the epidemiological findings. Positive and negative results can be misleading or difficult to interpret. So they have to be very wisely chosen and the microbiologist should decide that what environmental samples are to be collected. There's again a problem in moving the slides. Then the calculation of the HAI rates. So how do we know that the rates are increasing, or then only will we suspect an outbreak? The frequency of infection can be estimated by the prevalence and incidence rates. The rates are obtained by dividing a numerator by a denominator. The numerator is the event of interest, which can be a number of infections or the number of infected patients observed. The denominator can be any of the following, like the total population in which the event may occur, the at-risk population, or the number of patient days at risk. Now we'll see with examples also for example, the prevalence rate, the number of patients with HAI at the time of a study. For example, the number of patients with COTI at the time of study divided by the total number of patients observed or exposed to the catheter, urinary catheters at the same time into 100. This will be the prevalence rate of COTI. The cumulative incidence rate or the attack rate, the number of new infections acquired in a period divided by the total number of patients observed or exposed at the same time into 100. Then risk adjusted infection rates. These are the incidence rates per patient days. Number of new HAI pooled throughout the months divided the patient days of stay into 1000. Then incidence rate per device days. Number of new HAI pooled through the months divided by the device days into 1000. So these are few exercises which will help us understand to calculate the surveillance rate for example, the sepsis rate, the number of at-risk patients in 1 month, that is the newly admitted patients, plus the patients carried over from the previous month who are at risk of developing sepsis. This is 242. The number of sepsis cases identified is 15. So the prevalence rate or percentage will be the number of sepsis cases divided by the number of at-risk patients into 100. That comes out to be 6.2. Then calculating the ventilator-associated pneumonia rate, for example, the number of ventilator days in the pediatric ICU, it is 801. The number of ventilator-associated pneumonias in pediatric ICU, 5 cases. So rate per 1000 ventilator days would be number of ventilator days, number of ventilator-associated pneumonias divided by the number of ventilator days into 1000. And that comes out to be 6.2 again. Similarly, the the UTI rate, total number of patient days of stay during a specified time period, the number of UTI cases, the rate per 1000 patient days is the number of UTI divided by the total patient days into 1000. So once we know the cases, then we are supposed to formulate the hypothesis. Formulating hypothesis to explain the observed increase in the incidence and look into the associations, formulate a hypothesis on the type of infection, whether it is an exogenous or endogenous, and tentatively identify the source and the route of infection. So the hypothesis, once formulated, has to be evaluated, and so that additional studies can be performed if necessary. A hypothesis is tested about the relationship of a disease to a specific cause. To determine the cause and effect relationship by conducting an epidemiological study that relates the exposure of interest to the outcome of interest. The typical study designs are cohort, case control, and experimental designs. They determine the appropriate approach to surveillance depending on the issue being surveyed and the available resources. So the analytical epidemiological studies, they include the cohort studies, which can be prospective or retrospective. They include everyone who could have been exposed. A cohort study is feasible only when the population is well defined and can be followed over a period of time. The hypothesis here is tested by calculating the relative risk or the risk ratio. It is defined as the attack rate in exposed group as compared to that in the unexposed group. So if it comes out to be more than 1, then the risk ratio is considered to be significant. That is, the hypothesis is true. Then the analytical epidemiological studies include case control studies that are retrospective. They compare the exposures among ill persons, the case patients, and the non-ill persons. They can be useful for supporting your hypothesis if no obvious source is identified, but they are not always necessary. They are time consuming and challenging, and small number of cases limits the power of the study. And once we have formulated the hypothesis and analyzed and identified the source, then we need to implement the control measures, which include isolation, cohorting, drug and product recall, etc. The balance between the preventing further disease and protecting patient care is crucial. Protecting credibility, the chain of infection. We have to stop the chain of infection. The general infection control practices that prevent nosocomial infections are: we begin with hand hygiene, and the other is standard or universal precautions. The isolation precautions as and when required according to the source pathogen, like the contact, droplet, and airborne spread. Environmental cleaning and disinfection, the biomedical waste management, disinfection and sterilization of the medical devices and patient care equipment, enhanced healthcare provider education and training, cohorting patients or staff, and maintaining adequate staffing levels. So the outbreak control measures, depending on the type of suspected pathogen, they can be classified. For example, if we are suspecting the contact transmission, then isolation precautions along with barrier protection are to be followed. If we are suspecting airborne transmission, then an isolation in negative pressure ventilation and use of N95 masks. Droplet transmission, then isolation in where negative pressure is not required and a 3-ply surgical mask is sufficient. Foodborne, elimination of the food at risk to evaluate the food handlers. Waterborne, checking the water supplies and liquid devices, and the use of disposable devices. So now the next step is to communicate the findings. We have identified the source, we have formulated the hypothesis, and we have uh, started the infection control precautions. But now we have to communicate during the investigation of an outbreak. Timely and up-to-date information must be communicated to the hospital administration, the department or the unit concerned, and in some cases to the public also. Develop a means for disseminating the results to those who have a need to know, example, those involved in improving those outcomes, and those who may suffer from this outcome. For example, if there is a breach in the sterilization and we are supposed to go for recall, then the patients on whom those surgical supplies have been used, then the patients have also the right to know that information. It includes the measures to prevent such outbreaks in the future, and media attention is desirable if public attention is needed, like media played a very important role during the COVID outbreak. Then writing the final report. This is a final report on the outbreak investigation should be prepared within 30 days by the epidemiologist. It should describe the outbreak, interventions, and effectiveness, and summarize the contribution of each team member participating in the investigation. It should also make recommendations to prevent future occurrence. This report can be in the medical literature and may be considered as a legal document. The surveillance has to be maintained and followed to curtail the further spread. Follow-up investigation to determine if there are additional case patients, decide if the outbreak is over, and document effectiveness of control measures. Determine if the outbreak has spread outside its original area or the area where the interventions were targeted. So to conclude, outbreaks do occur in healthcare and they need prompt action, early identification through surveillance, infection prevention to curtail further spread, communication, and more importantly, team effort. That is all. Thank you.
Thank you so much, Dr. Fatima. It's a very well explained, simple, and comprehensive presentation. Very nice. I mean, I think you've covered all aspects of outbreaks and especially pertaining to healthcare associated infections. and very well explained on how do you evaluate hypothesis, which is not very well known to many of the people. Very
Thank
nice.
you.
And I would now welcome all participants. If they have any questions or any challenges to be discussed with ma'am, then we can go ahead. I don't see much any questions in the chat box as of now pertaining to this. And even the interactions are very good, Dr. Fatima, because a lot of good, questions for the participants to actually answer. So very well done. Thank you so much.
Thank you so much. Thank you.
Yeah. So participants, is there any? Yeah, there's Anamika has asked, ma'am, is there any additional steps to be taken in a community setting outbreak?
The steps of outbreak management are basically the same for the community also. They are the same.
That's right.
Are in, yeah.
Yeah. So are they the same? And anybody else? Any other questions
The
from the
only
participants?
thing is that we need to inform the community. We need to inform the preventive measures in the community setting. Like
That's
we
right.
were doing in we all have learned that during the COVID pandemic.
That's true. That's true. So any other questions for Dr. Fatima? Yes, participants, please put it in your chat box, or you can unmute and speak if you want to. No? No other questions? Uh, there's a lot of very nice feedback, Dr. Fatima, very informative session and a very good session. So that's for you.
Thank you so much. Actually, I'm not that comfortable in online sessions. I feel when I connect with the people in offline mode, I'm unable to connect in online. I don't know why.
Yeah, that's a
So
common.
I felt I was going monotonous during my session. I'm sorry
Nahi,
for
it
that.
was very good. It was clear and comprehensive. I mean, I think probably uh, that happens to all of us. There's one more question, Dr. Fatima. Is there any special form for capturing outbreak?
Yeah, there is the outbreak investigation form. We have audit forms also. Yeah, we have different forms, particularly the healthcare outbreaks. We have the bloodstream infection form, CLAPSI. You can see the CDC guidelines, CDC website. They have
That's
beautiful forms for all different types of healthcare associated infection outbreaks.
that's right. That's right. Um, Reena has asked, can you please include MCQs? In what? In the presentation? I think it's already there, the questions.
Actually, I was unable to go for how I was planning for a poll, but I was unable कि कैसे करना है वो,
हाँ,
so I just put it
but
in
ये
the
भी ठीक
slide.
है, ये भी ठीक है तो अच्छा ही. I mean, it came out quite well actually, because people answered on the chat box, so it's wonderful. It's fine. Any more questions from the audience? So I don't think there are any more questions, Dr. Fatima, and thank you once again for a lovely session. Very well explained, and I think it's very clear as to how an outbreak should actually be done. So thank you again for your time.
And
Thank
thank you,
you all.
Dr. Sukanya, for your timely feedback. I had made the changes suggested, but I didn't decrease the number of slides because the time was 1 hour. So, but the line listing and those feedback I had added.
Yeah, it
Thank
was
you so much
wonderful.
for your valuable suggestions.
You're
Thank
always
you.
welcome. It's a pleasure. Thank you so much. And thank you all participants too. And, Sandmed, Mr. Lalit, and from IFCAI Spurti, thank you for the technical help. Thank you all.
Yeah, thank you everyone. And also with this, I think we invite every one of you to be a part of the panel discussion, which is going to be on next Tuesday, November 8th. So all your queries and any other questions with regards to the IPC and the theme we had can be put in there. We are going to have all our speakers and moderators and panelists during the panel discussion. So we invite you all to be a part of the panel discussion, which is going to be highly interactive and which is more of a doubt clearing session. And we expect all of you to actively participate in the same. So thank you, everyone. Thank you, Dr. Fatima Khan, and thank you, Dr. Sukanya,
Thank you, Lalit.
for helping us with this session. And it was wonderful, I think.
Thank you.
Thank you, everyone.